Asthma is a chronic inflammatory disorder that causes hyperresponsiveness of the airways, leading to variable and irreversible flow of air into the lungs. When we talk about drugs used in asthma, essentially we have lots of choices. We have the bronchodilators, the anti-inflammatory agents, and the leukotriene pathway inhibitors. We have a choice of a number of anti-inflammatory agents, including the mast cell release inhibitors, antibody-based therapy, and of course steroids. And in this video, we are going to go over each of the different group of anti-inflammatory agents used in asthma. As you know, asthma is a chronic inflammatory disease, so obviously one of the treatment strategies is to treat the underlying inflammation of asthma, and corticosteroids is one of those anti-inflammatory agents that are most extensively used in the management of asthma. Corticosteroids do not relax airway smooth muscle directly, but they do produce an increase in airway diameter by decreasing inflammation. Corticosteroids can reduce the frequency and the severity of chronic asthma attacks. Corticosteroids suppresses the inflammation in asthmatic airways, and this action underlies the clinical improvement in asthma symptoms and in the prevention of exacerbations. At a cellular level, corticosteroids reduce the number of inflammatory cells in the airways, including eosinophils, T lymphocytes, mast cells, and dendritic cells. And this effect of corticosteroids are produced through inhibiting the recruitment of inflammatory cells into the airway, by suppressing the production of chemotactic mediators and adhesion molecules, and by inhibiting the survival of inflammatory cells in the airways. Additionally, corticosteroids enhance beta-adrenergic response to relieve muscle spasm. They also act by reversing mucosal edema and decreasing vascular permeability by vasoconstriction. Essentially, corticosteroids inhibit the late phase reaction by inhibiting inflammatory response, and they have no effect on the immediate hypersensitivity seen in asthma. So by blocking the late reaction, they prevent the increased airway reactivity observed, and all of this aid in the resolution of bronchospasm in asthmatic patients. How corticosteroid does all of this is by interacting with specific receptors in tissues to regulate expression of corticosteroid responsive genes. If you look at this diagram, inflammatory genes are activated by inflammatory stimuli such as interleukin-1 beta or TNF-alpha, resulting in activation of the I-kappa B kinase 2 inhibitor, which then activates the transcription factor NF-kappa B. A dimer of the P50 and P65 NF-kappa B proteins translocate to the nucleus and binds to specific kappa B recognition sites and to co-activators, such as the cyclic AMP response element binding protein and the P300 CBP activating factor, which have intrinsic histone acetyltransferase activity. This results in acetylation of core histone H4, resulting in increased expression of genes encoding multiple inflammatory proteins. After activation by corticosteroids, glucocorticoid receptor translocate to the nucleus and bind to co-activators to inhibit histone acetyltransferase activity directly and recruiting histone deacetylase HDAC2, which reverses histone acetylation, leading to suppression of these activated inflammatory genes. Corticosteroids in the management of asthma are generally given by inhalation or oral preparation. Corticosteroids do not cause their effects rapidly in asthma. The onset of action might be as late as 3 hours, and the duration of action ranges between 6 to 12 hours. Administration of corticosteroids by inhalation can greatly reduce the potential of serious side effects. So the newer corticosteroids such as beclomethasone, budesonide, fluticasone, and whatnots have very low bioavailability due to extensive first-pass metabolism and are well suited for inhalation use. However, even these agents have some potential for adverse effects. Oropharyngeal candidiasis, which can be minimized by raising the mouth and gargling with water immediately after inhalation, has been reported. There are also reports of dysphonia, which is hoarseness of voice, dryness of mouth and throat, and occasional coughing. These are all due to upper airway irritation, and they can be minimized by using a spacer attached to the metered dose inhaler, which decreases the oropharyngeal deposition while increasing the lower airway deposition of corticosteroids. Systemic adverse effects from short-term oral use of corticosteroids include hyperglycemia, edema, and rounding of facial contour. Though highly efficacious at blocking inflammatory phase of asthma, corticosteroids have a number of long-term side effects which limit their oral use. Long-term side effects of oral corticosteroids use may include endocrine suppression, increased risk of infections, osteoporosis, cataract formation, fluid and electrolyte imbalance, as well as impairment in growth and development in children. Corticosteroids, specifically methylprednisolone, is available for intravenous use, and this is usually reserved for the management of status asthmaticus, which is severe asthma attack. Let us now move on to omalizumab. Omalizumab is a recombinant humanized monoclonal antibody against human immunoglobulin E or IgE. It is a treatment option for patients with moderate to severe allergic asthma whose asthma is poorly controlled by corticosteroids and long-acting beta-2 agonist bronchodilators. In patients with allergic asthma, the allergic cascade is initiated when IgE bound to the high-affinity IgE receptor on the surface of mast cells and basophils. This then results in the degranulation of these effector cells and the release of histamines, leukotrienes, cytokines, and other mediators, which are responsible for the pathophysiology of allergic asthma, including airway edema, smooth muscle contraction, and altered cellular activity associated with inflammatory process. They also contribute to the signs and symptoms of asthma, such as bronchoconstriction, mucus production, chest tightness, nasal congestion, so on and so forth. Omalizumab binds to IgE and prevents binding of IgE to high-affinity IgE receptor, thereby reducing the amount of free IgE that is available to trigger the allergic cascade. In other words, it lowers free IgE serum concentration to undetectable levels and prevents IgE from binding to mast cells, preventing the release of histamine and leukotrienes and thereby inhibiting allergic inflammation. This monoclonal antibody for IgE is reserved for patients who have demonstrated IgE-mediated sensitivity to asthma and have an IgE level that can be reduced by subcutaneous injection of omalizumab. Omalizumab is given by subcutaneous injection every 2 to 4 weeks. This is a very expensive drug. Last I checked, in Malaysia, the recommended price is about 2,000 ringgit per vial. Common side effects of omalizumab include headache, tiredness, joint or muscle pain, cold symptoms, and itching or rash, among others. One of the concerns with regards to omalizumab is its potential in increasing the risk of malignancy. In 2003, a group of researchers from the UK and the US published the result of a study in the European Journal of Immunology, in which they found strong evidence that IgE antibody plays a significant role in the recognition and inhibition of malignant tumors. Omalizumab is not selective in the way it blocks IgE receptors from binding to allergens, and this may interfere with the way these antibodies detect pre-cancerous cells. Although a review of a 5-year SAFE study by the FDA found no difference in the rates of cancer between those patients being treated with omalizumab and those who were not, the regulatory body acknowledges that due to limitations in the study, we cannot rule out a potential of increased cancer risk. At present, the high cost, the need for subcutaneous injections, and the concern about its long-term safety restricts the use of omalizumab to patients with severe asthma that cannot be controlled by other drugs. Let us now move on to the last group of anti-inflammatory drugs used in asthma, which are the mast cell degranulation inhibitors, for example, Cromolyn and Nedocromil. Pre-treatment with either Nedocromil or Cromolyn results in inhibition of mast cell degranulation, blocking the release of chemical mediators of inflammation. By its action, Cromolyn is effective in blocking the late-phase reaction in asthma, and so is Nedocromil. So both of these drugs prevents the extrusion of granules containing the mediators of inflammation to the cell exterior, and for this reason, Nedocromil and Cromolyn are often classified as mast cell stabilizer. Additionally, both of these drugs inhibit the recruitment of neutrophils and eosinophils to the pulmonary epithelium by inhibiting neutrophil chemotactic factor. Cromolyn and Nedocromil are inhaled as aerosol by a compressed method inhaler. Both of these drugs are not capable of reversing acute asthmatic bronchospasm, and they cannot be used to treat an acute episode of asthma. Cromolyn and Nedocromil, when used prophylactically before exposure, will inhibit immediate allergen-induced and late-phase allergen-induced airway narrowing, thus preventing symptoms of asthma. Essentially, they are used just before exposure to conditions or substances that might trigger an asthma attack, for instance, the exposure to allergen such as pollen, aspirin, chemicals, cold air, or air pollutants. The onset of action for these drugs are within 10 to 15 minutes, and the duration of action ranges between 4 to 6 hours. So what about the side effects? Please have a read of your recommended textbooks and take note of the common ones. Also find out if there are any particular concern with regards to the use of either Nedocromil or Cromolyn. Let's do a quick recap of the anti-inflammatory agents that are used in the management of asthma. First of all, we have the corticosteroids. Corticosteroids inhibit the synthesis of virtually all cytokines. They also inactivate NF-kappa B, which is the transcription factor that induces the production of TNF-alpha and other inflammatory agents. Corticosteroids are the first-line therapy for chronic asthma. And then you have Omalizumab. Omalizumab is a monoclonal anti-IgE antibody. Omalizumab binds to IgE and prevents the binding of IgE to high-affinity IgE receptor, thereby reducing the amount of free IgE that is available to trigger the allergic cascade. Omalizumab is used in allergic asthma, resistant to corticosteroids, and long-acting beta-2 agonists. And then last but not least, you have the Cromolyn sodium and Nedocromil sodium, which are mast cell inhibitors. Both of these drugs inhibit the mast cell degranulation, blocking the release of chemical mediators of inflammation. Nedocromil and Cromolyn are used prophylactically to prevent the development of asthma upon exposure to triggers. If you like this video and if you understand what was covered so far, hit like and click subscribe if you haven't. We will cover the next group of drugs used in asthma in the next video.